Terrific. I want to be very respectful of everyone's time. So let's go ahead and get started. Katie and Ed, thank you so much for being here today to deliver the grand finale of our Playbook Masterclass series, diving into specific considerations for remote monitoring in public health. Welcome everyone on the line. If you haven't attended one of our Playbook Masterclass sessions before, you are in for a treat this afternoon. Before I hand off to Katie and to Ed, let me just orient you very quickly and give you just a couple of housekeeping notes for our session today. So first of all, always want to remind folks, we'll always be respectful and let you know, we are recording today's session. What that does mean is that this will be available later for your colleagues. We will post this recording along with the slides, both to playbook.dimesociety.org and the Dime Society website. Katie and Ed are going to take us through some sort of terrific elements of the playbook, really guiding you through opportunities to think about the thoughtful use of sort of remote patient monitoring and public health initiatives. And then we will spend a good amount of our time in discussion. So I hope that many of you came with questions. There's a couple of ways that you can engage in discussion. As Katie and Ed are presenting, you can feel free to type those into the chat box or the Q&A. I'll be keeping an eye on those and we'll get to them at the end of their presentation. Also, you can ask your question live. So once we move across to discussion, feel free to raise your hand and then I'll unmute you and you are able to ask your question live to Katie and Ed. So with that, we've got a great group assembled today. Katie and Ed, thank you for being here. And I will hand over to you.
Wonderful. Many thanks, Jennifer. I'm going to kick it off and then do a shift midway with a handoff to Katie. So thanks everyone for tuning in. This really has been an amazing series that not only delves a little bit deeper into the playbook as Jennifer mentioned, but really now start attributing a lot of the information that's captured there into some specific research areas. And so the next slide, Jennifer, if you don't mind, has been used by a number, I think perhaps even all of the previous master classes. And I was happy to reintroduce it for ours because it really just ultimately paints the picture for what it is we're trying to accomplish here with the use of sensor technology, with the use of approaches for capturing digital health measures. And so for me, when I look at this, I think of the iceberg metaphor where what you see above the waterline is really that episodic capture of health data. So in fact, I was talking this morning with a colleague in which we're trying to frame out a study for examining maternal health. And you think about the time points along pregnancy, which are captured very much episodically compared to a potential and an opportunity for capturing those vital signs, those health measures in a continuous fashion. What type of questions that you could potentially now ask, what you could potentially now learn and glean from that type of new context of information. And so this is really what fuels the excitement for me with regards to thinking about research in this shift from an episodic to a more holistic capture, regardless of what type of research question you're looking to ask. And so the next slide is really the opportunity for us to now apply that in a variety of different contexts. So the previous master classes have either very specifically stepped through clinical research or clinical care as a scenario for attributing our learnings and understandings of applying digital health measures, as well as subsets of important topic areas like ethics and regulations and so on. But as Jennifer mentioned, we're going to focus a bit on public health and some of the areas where Katie and I have been successful and where we've been challenged with regards to leveraging digital health technologies, sensor technologies, and understanding of how to deploy these in a variety of different studies. So specific to public health, I think it's important to recognize typically what we think about in terms of the pillars for this particular area. And that is some level and understanding and attribution for surveillance of a particular health context with the goal to identify a certain set of risk factors, for example, and then ultimately being able to evaluate those to determine some level of intervention back to the population that you're potentially interested in, and that implementation strategy and implementation approach comes with a whole other set of considerations as well. And so the next slide is just a quick kind of tangent with regards to very specifically how we're applying the playbook with regards to a new partnership that has been in the works now for the past 6 months between Scripps Research and Care Evolution. So the foundation for the Digital Trial Center, which is what we've created between those two entities and partners, is really rooted in this approach of and philosophy of decentralizing research. So looking at where data is captured and how the data are captured. And so I've had my share of centralized research in the traditional sense with regards to leveraging in-person, in-clinic, brick and mortar, really focused on leveraging the gold standard of health measure captures, which are typically, again, within a clinic, leveraging a provider, a physician. And then this shift for me over the past few years, several years now, was how do we embrace this paradigm of decentralizing that traditional model into something that is now embracing the digital technologies that have come to bear, both clinic and research grade, as well as those technologies that are off the shelf. And so this movement towards a remote, siteless paradigm that leverages the capture of health measures digitally, but is also putting together a participant experience that can be self-guided, is ultimately the foundational elements and the core of the Digital Trial Center of decentralized research, and embraces so much of what the playbook is looking to assert and to provide information on, so that others can do similar implementation and launch similar types of studies. So an exciting time for sure, because I feel like everywhere I turn, this is a topic that seems to be popping up more and more. And so we'll step through a couple examples of how we've been leveraging this philosophy and this paradigm in our research. So the next slide is starting to step through considerations really across all three of those domains that were mentioned previously in terms of clinical care, clinical research, and of course, public health. The kind of three levels of focus illustrated here fall to an understanding of measures, what it is you're going to measure, the technology that's appropriate and suitable for capturing those measures, and then an understanding of not just the technical implementation and dissemination, but also what it means from a participant perspective with regards to equity and justice, not only in how you return data, but also an understanding of what the data and what your research questions represent. And so I'll quickly point out, I think it was Tom from Genentech from a previous masterclass that aptly stated, picking that technology first before having a full understanding of the measures is akin to really focusing on a solution in search of a problem. And so taking that time to truly understand, all right, if this is a public health context with regards to surveillance, or I'm truly looking for a specific to understand a specific set of risk factors, developing those measures that speak to those questions as really what's the important first step. And then the technology will come, because then you have an understanding of what type of observations you're looking to make, and how you're looking to move the field forward in terms of additional knowledge and novel insights towards answering those questions. And so the next slide is really a further understanding that I think is linked to the process of developing those appropriate health measures, and that is identifying those meaningful aspects of health. So it's for me, this is not asking a question just to ask a question, right? So you're not coming up with a measure that you're looking to observe just because you can, but also for tying that back into something truly meaningful. And that's, I hesitate, but I think it's true. I'll say that's relatively easy in a public health space, because we have trend analysis, we have population understanding, we know what the public health crises are, we know what the public health issues are, but we don't necessarily understand them, and we need more insight across the board for better framing and development of solutions towards those health issues and health crises. So for public health, as kind of stated here, really one of the primary differentiators is that you're really looking now to either glean those understandings from a broad population, or to push those understandings out into the context of a broad population, or both. And so the variance is a consideration here in terms of the size and scope and makeup of the populations that you're looking to serve and looking to understand. So the next slide is really starts us down some specific examples here, and there's no better example in public health than surveillance. And given our current times, there's no better example of surveillance when it comes to COVID-19 and the global pandemic. And so what's highlighted in the playbook is work that actually came out of Scripps Research. So Dr. Jennifer Radin, who really led some seminal work that has led to a variety of additional research studies and insights focused on leveraging wearable data in the context of understanding influenza and influenza-like illness at a population level. And this really set the stage for, and this is a bit of a shameless plug, but it's an appropriate segue. It really set the stage for potential understanding towards COVID-19, which very much falls into the category of influenza-like illness. And so this was a timely publication here in the Lancet that came out in January with a companion piece from Giorgio Quer, who's also on the Scripps research team, that came out a little bit later, that really started to link the power of exploring digital health measures from wearable sensors like a Fitbit or a Garmin or an Apple Watch, and seeing if we can identify some level of correlation with incidence of disease, in this case, influenza-like illness. And it was a perfect setup for, although not necessarily was the original intent, but it was a perfect setup for a potential understanding of COVID-19 and the pandemic that followed in the months after the publication of these studies. And so we've been leveraging this shift from how do we have an understanding at a population level to now using those digital health measures at an individual level, shifting the goal of really developing some level of early prediction, a model that would speak to early prediction or early detection of COVID-19. And happy to report that we have some preliminary findings published in Nature Medicine that just came out last week in support of that. So I'd like to think that we're well on our way, but just a pretty exciting example for us not the least of which were the research findings, but the speed in which we were able to pivot and develop these studies in response to the pandemic. So the next slide really shifts from a bit of a specific example to now starting to think about the considerations as we build out these studies. And again, not the least of which is handling and understanding of data, especially as we look to leverage platforms such as the ones that we're using in partnership with Carevolution, the My Data Helps platform, in which its strength comes from its ability to be somewhat agnostic in the different devices that it can connect to. So we have participants in the detect study that have Garmin's, that have Apple Watches, that have Fitbits, that have a variety of different sensors that connect to Apple Health Kit or Google Fit. But then, so that is, I think, for the most part, delivers a positive user experience because we have broad eligibility for those that have wearable devices. But on the back end and on the data analysis side, you do have to think very carefully about what does the data interoperability and compatibility look like because of the different technologies that are being leveraged. And there's an additional example here that's provided in the playbook with regards to 3-lead ECG in further understanding of COVID-19. So data interoperability is just one aspect. We also start thinking about, as we frame out these studies, if we go to the next slide, considerations around the fit for purpose. So this is, I love this slide for a number of reasons, not the least of which is the landscape view of consideration. So of course you have to think about the selection of the technology that has some level of verification, some level of analytical and or clinical validation attached to it, so that you can select and use and understand the appropriate technology for the research questions that you're asking. But then there's a whole slew of downstream or considerations in parallel that need to connect with that in terms of developing out a research plan and a research and study design. And this includes security, data rights and governance, utility and usability, economic feasibility. And for the purposes of technology selection, it certainly spans all of this in terms of security, whether or not there are privacy considerations that need to be part of your matrix of selecting the appropriate sensor. Data rights and governance are things that you would establish as you create this partnership with the participant. Utility and usability, for example, there are this balance of leveraging sensors, for example, that are a few years old that have some core functionality. So they may provide physical measurement through step count and sleep duration. But now the new model has breathe rate and heart rate variability. So an understanding of, okay, I can get more participants that may have this device, but now I have to think about my data considerations or if you're pushing devices out to participants, the understanding of how to use that device and how difficult is it going to be for them. So remember, we're building all this on the paradigm that we've taken the brick and mortar clinic out of the picture. That doesn't necessarily mean that the participant is left on an island, but as a researcher and as somebody that is conducting the study, you now have to think about, all right, well, how am I going to provide that support? What is the proxy for the utility and usability instruction and direction that they would typically get in a clinic or in a brick and mortar facility with a research coordinator in person? And so the next couple of slides that I'll just step through briefly, and then I'll kick it over to Katie, just some additional considerations around the ecosystem. So We've talked a bit about the sensor, the selection of the sensor, considerations of privacy and security, the data collection and interoperability. But then there's the back end. So now you've collected all of that data. What does it mean in terms of your ability to process it? What does algorithm and modeling look like? Have you set yourself up for success in terms of pulling the appropriate data types into the platform that you're using for the study? And then there's the return of that information back to the participant. Is it going to be in real time? Is it a summary of the information that you've collected? Is it a much further downstream in terms of, I collected this data, I've analyzed it, I've now created this model and algorithm, all of which takes a significant amount of time. So thinking about pushing that back to the participant as well. And so we're very much keenly focused on this particular model as we think about another study that's looking at prediction of glycemic response in individuals with type 2 diabetes, where we're looking to understand how does their nutritional intake affect their glycemic response. And we're looking to understand that through continuous monitoring of their glucose and physical activity and sleep and heart rate, with the hopes of developing some kind of personalized or individualized model to be able to return back to them. But there's a temporal component to that is extremely important in considering. And so what kind of return of information then can you provide in the interim as you look to kind of flesh out the larger goal? So the next slide is, if I recall, yes, the analytical validation. This is, I think, adjacent to some of the comments that I made for the previous slide, trying to get an understanding of that data quality. And again, using the example of the glycemic response prediction study called Progress that we're looking to launch in early next year. This is extremely important because we are pulling disparate data from a set of diverse devices, whether it's a continuous glucose monitor or a wearable sensor or self-reported information, all that's housed under the underlying My Data Helps app, ensuring that we're pulling the appropriate amount of data and that ensuring that we have a plan on validating the baselines that we're looking to establish as these data come in from different devices. The next slide is, and I think this is my last slide, and then I'll kick it over to Katie. This is another area where we tune into quite a bit because the opportunity for leveraging electronic health records very specifically is something that is very attractive to us for a number of reasons. It gives you some level of clinical background and historical capture of clinical information for your participants, but it also can potentially set you up for an understanding of health outcomes after you've collected a certain type of data, a certain set of data. And so leveraging our platform that has incorporated standards focused on electronic health record data is extremely important. HL7 and Fast Healthcare Interoperability Resource, or FHIR, are two extremely contemporary standards that have been adopted and embraced by the healthcare industry in the context of how they structure and how they develop their systems for transferring electronic health record data. So EHR vendors such as Epic and Carevolution and eClinicalWorks all have their proprietary systems, but ultimately HL7 and FHIR is an opportunity to pull data from each of those systems in a standardized way. And that is a game changer for the researcher, where we can now look at the real-time continuous data that we've collected from participants and now start to be able to potentially match that up with data that you would glean and insights that you would glean from the electronic health record. So this is an exciting opportunity for us, and this is just one example of standards that exist that can really provide a robust lens and a robust approach to your study design as you consider use of digital health measures for public health or for clinical care and research. So that's my spiel, and I will kick it over to Katie, who basically will say, well, that's all well and good, but, I think that's definitely a great companion piece to what I just laid out for you all.
Of course, that's how we do it. Everybody, can you guys hear me okay? It's not a real Zoom call unless somebody forgets to go off mute, but we're doing okay this time. Well, welcome to everybody. And for those of you who didn't, catch any of the previous master classes or maybe the kickoff of the playbook, I'll go ahead and introduce myself quickly. I'm Katie Buckamotes. I'm at Scripps Research, been with Scripps Research for about 5 years. My life previous to that was around behavioral science. So really interested in consumer behavior, patient engagement. For the last several years, along with a great team at Scripps Research, we've led the Participant Center for the All of Us Research Program. Prior to that, we had one of the first decentralized trials. As Ed mentioned, he just came on board, but he's not new to the team. He was at the NIH for a long time, working for the All of Us Research Program as the program officer for the Scripps Award, and has recently come on to help us build out these decentralized trials that he mentioned within the Digital Trial Center. So we've been involved, Ed and I have been involved, and then Steve Steinhubel, who you might have caught last week on the master class. If you haven't, it's on recording, have really been thinking about, how can we continue to contribute to things like the playbook, which are, open science available for everybody, starting to build this framework of how do we do this successfully, taking the knowledge from across the field. So notice that one of the attendees is already putting in standards as it relates to the last slide. These are the sorts of things that we really want: engagement from, everybody that's listening in on these classes. And Jennifer will talk a little bit about where we go next. So as Ed said, I'm gonna sort of talk about, yes, everything's all in good. So I think a lot of the last master classes have talked and touched on a lot of really important critical things as we think about, the type of technologies that we're selecting, how we're deploying them, how we're thinking about things. And I picked another slide to start off mine that, just similar to Ed, he's saying, well, everybody's picking this iceberg slide. I think I went through again and re-listened to a lot of the master classes over the weekend, and this concept of trust keeps coming up, right? Trust is critical. It's a critical component. Without trust, we can't have, the engagement from participants that we need. We can't have the support from, public health bodies and all of these things. So I think the playbook does a really nice job, and this is just one of many of the slides, outlining what are the foundational elements that we must have as we think about remote monitoring, as we think about decentralized clinical trials. We've got to have that trust in there. We've got to have transparency. We've got to have data security. At Scripps, the number one, we have our rules, right, that have been, part of the group for many years now. And the first is around this do no harm, right? Participant safety is the number one thing that we care about. And that extends on to data security, privacy, keeping our participant data secure. But this is just the foundation, right? So we need to have that initial trust. And it's even more so important when we're doing it outside of that traditional brick and mortar. But the next slide shows you, and again, I'm going to touch on this, our favorite slide of the 400-page deck, again, one more time, is, just because we have the capabilities now to go out and capture all of these data on people out in the wild, doesn't mean that people are going to be willing to first capture the data, wear a device. It doesn't mean that they're going to consent to share that information. It doesn't mean they're going to continue to do, everything that we built in our protocols to do. So the next slide talks Steve mentioned this in last week's masterclass. He gave an example of, we were running a study probably, I don't know, 5 years ago, where we had a device that people eagerly signed up for. Yes, I want to consent to get a free, smartwatch in the mail. I want to wear it. I want to connect it to the study. This was a subset of another study that we were running. And what he described is, yes, we sent it out. It was great. And like less than half of the people even opened the box and connected it the first time. And much less wore it through, the entire, period. I think it was like 4 months or something that we had anticipated that they would wear the watch and continue to connect and provide the data. So what this means is, if you look at the next slide, and this is something that I think the playbook touches on quite a bit, right? Patient engagement is vital to the success of this process. And this is an area that I hope, as the playbook evolves even more, that we do a deeper dive into this, because this is where we spend a lot of time focusing and thinking about at Scripps Research. So it's one thing to get, 10, 50, 100 patients to do something for a while. It's another to do it in the types of trials that we're trying to run and that we do run here at Scripps, where our pilot studies are 1,000 people, right? We tend to get multiple thousands, we get tens of thousands, hundreds of thousands, and even in all of us, the aim is to get 1 million or more people. So if we think about tens of thousands, hundreds of thousands of people engaging with us over a long period of time, we need to rethink how we think about our patients, our participants, our subjects. And so one thing, if you'll allow me just to go off script a little bit here, I want to talk about, how we think about this here at Scripps. So I mentioned my love is sort of the behavioral science aspect. And in a previous life, right after grad school, I went to work at Disney. I was an Imagineer working at Disney Research. And one of the things, I learned a lot of things about running randomized control trials on large like consumer behavior stuff in hotels and in the parks. But one of the most amazing things was when I was going through my onboarding at Disney, was the way that they name everything, right? You come in and, during those first couple of weeks, you are told, we don't have customers here, we have guests. Right? Everybody who comes in through Disney's doors is a guest. Never see the word customer anywhere in any deck and any, presentation of anything. And then the employees are cast members, right? They're the cast members. And then I was an Imagineer because I was part of the science group. But what amazed me is how quickly that helped with just the orientation and the onboarding of every employee that came through the door. They didn't need to be, told what an employee should do. This is our employee handbook of how we should treat people. These are all of these things. Cinderella didn't need to know, what she should be doing when she was in the parks, right? Because when you're, in addition to the naming of you're a cast member, you're part of the show, right? You are in character no matter what. And that goes from anybody from Cinderella to the person sweeping up the thing, sweeping up the garbage on the side of the street. There's when you go onto the Disney campus, you go from backstage to onstage, and the second that you're on stage, you know how you should act. And so what was surprising to me is I realized how quickly just the nomenclature worked, right? You knew immediately how you treat people, how you treat your guests as guests. You knew when you were on stage as a cast member that you were part of the show. And so it just gets rid of a lot of the guesswork, because you automatically have a mental model of, how people should interact in that situation. And I think we're making some progress here when we talk about clinical trials with patients too. For a long time, they were research subjects, right? And that was something that we weren't comfortable with. It was kind of a lab rat. It was all of these things. We made some progress in calling them participants. They're part of this process, right? But now at Scripps, what we really try and do is think about them as participant partners. And when we talk about the word partner, it automatically gives us this mental model that both sides should be gaining value. Both sides should be gaining value at every step of the way. And so I think things as little as that force us to start to think about, when we're developing clinical trials, when we're developing large-scale research programs, if we're treating people truly as a partner in the research, where are they getting value, right? So this is where the next deep dive, I think, we want to go as an industry, is figuring out at every step of the way, where are participants and where is the public getting value from what we're creating. So there's a couple of different ways to do this, and it touches on this in the playbook a little bit. So if we go through the next couple of slides, it can give you a couple of examples, making sure these things are a two-way street, right? Is it voluntary? Is it accessible? Are you gaining value? So there's some pro tips in here, and if you go through the next couple of slides, I'll give some examples. You think about usability, you think about utility. Are we gaining value as a participant in the process of gaining all of these things? But I don't know if it's really here in the slides, so I'll again sidebar a little bit and think about, how are we giving value back to participants? We think about it in a couple of ways. Are we allowing them to have access to data in real time? And there's a whole section in the playbook that talks about sort of a business logic of when can we give information back? And I think I actually have this in the next slide, Jennifer. Maybe it didn't make it through. Yeah, so this is a good one. It starts right here. When should you be starting to share your digital outcomes with participants? So like Ed mentioned in the DETECT study, which is the COVID-related one, when are we sharing back their activity data that they're sharing with us? When are they, looking at their trends and resting heart rate? Can we start to provide that back for an individual? When does it make sense in a clinical trial? When maybe does it not make sense? So the playbook does a really nice job of helping us decipher, when and where and how, and all of the considerations that we need to think about when we're returning information back in real time or at a later stage in the trial with the participant. The other thing it does touch on a little bit is how we can incentivize. How can we make sure that the burden and the benefits are aligned, both on the individual level and on the population and community level. So, but I do think we need to go a little bit further, and this is where I'm hoping that we go to next, because when we talk about it in our research team, and there's probably quite a few people on the call today that are part of our research teams or our partnerships, but we think about, okay, going back to this concept of our participants as partners, every time we're asking for something, what are we giving back, right? And so usually when we ask the research teams about, what value is the participant getting, it falls into two buckets, right? It's the data that we're giving, right? Because that's what we're interested in, and that's what the focus is on. We're very interested in resting heart rate, so we assume everybody else is interested in getting their resting heart rate back or their sleep activity. And oftentimes our quantified solvers go even deeper. They're like, if they're giving us, information about their mood and their sleep, then we can combine the two and we can give it back in a really valuable way. That's great. That's like one bucket of giving value back to participants. Another is the other bucket that things typically fall in is incentives. Oh, well, they're getting, a free Fitbit, or they're getting, a $25 gift card or a $100 gift card, and we're incentivizing them to complete the trial. Those two buckets are very, very important. But I think in order for this to be successful and scalable, we need to think beyond those buckets of motivation, right? We think about things that a participant may get in a face-to-face interaction, in the traditional sense. They may not get in a digital sense, and those are in the digital space. And these are things like connection, validation, gratitude, being able to just converse with somebody and connect, be entertained, be curious, be all of those things that, be educated. Those are things that I think sometimes we fail to think about as a research team when we're thinking about providing value back, and things that sometimes slip through the cracks when we say, okay, we want to know what participants want out of this, so we set up a focus group early on, right? These are things also sense of belonging, validation, all of these things. They don't come up in a focus group, but these are valuable drivers in human motivation and human behavior. So thinking through all of the different ways that we can provide value back to an individual or the population as a whole, I think are really important, and for us to kind of break out of just like the two major buckets that we tend to talk about. And even within all of those buckets, thinking about the way to properly structure those to maintain long-term engagement. Because in order for this to be, really helpful over time, I think one is you need scale, and the other thing is you need long-term engagement for each of these things that we're trying to do. So that's where I hope we go next. And like I said, there's several things in here I've pulled from the slide deck. We can go through the next couple of ones, Jennifer. So we can think about, the previous slide talks about it a little bit here. When we think about, data sharing strategies you can do to maintain participant engagement. So some of it is the actual data itself. Some of it is strategy number one, share non-outcome data. So congratulations, you met your sleep things. Like those are things that I think sometimes are really valuable, but don't always come up to the surface. So these sort of pro tips are really, I think, useful. And I think that's basically where I know we wanted to leave probably a little bit more time than 15 minutes for Q&A, but I think I'll wrap it up there and open it up to any questions and comments from the attendees.
Katie, Ed, that was absolutely fantastic. Thank you for walking us through that. You covered an awful lot of ground in a short period of time. I'm keeping an eye open for questions coming in via the chat and the Q&A. Also, folks, if you want to ask your questions directly, please feel free to sort of raise your hand over in the attendee list. I wonder if I can dive in a little bit, maybe. Oh, in fact, let me just make sure I'm not talking over someone here. Okay, excellent. I wanted to ask Ed and come to you first. You talked about sort of the idea of starting to really understand sort of the measures that were coming in. And one of the questions I get oftentimes is around the sort of normative data sets. And I think about something even like, blood pressure, and you've described previously sort of that we need to start talking about these really prevalent conditions like hypertension as public health issues, and that's really helped my thinking. But we also have some evidence that when we are frequently measuring something like blood pressure outside of the clinic using sort of tools, that the reference points that we've become accustomed to over decades may no longer apply. How do we start to think about sort of handling that? And how do we disseminate that information as we start to draw sort of new understandings from this more frequently sampled data?
Yeah, I think I would argue that's a question for nearly every health measure that we're collecting. You really can couch it with that potential challenge. And so, when we think about it, whether it's blood pressure or whether we're just capturing step data or heart rate data, it's a couple of things. So we absolutely look to leverage the science that we know. And so, for example, with heart rate, we know what the expected intra-individual variation is going to be in resting heart rate from day to day. And then we can use that then to set our modeling and of the baseline to potentially identify what a significant change actually means. And that's an extremely important point, because I remember when I first, several years ago, when the first Fitbits of the world came out, and I was like, oh, I walked more than 3,000 steps. This thing is completely wrong. But once you have an understanding of, all right, it may be completely wrong every single day, but it's actually delivering a relatively consistent value to you. And so you can then use that value for when you actually do start training for a marathon, that value will jump up. And so you start framing your questions around, how do I use that known quantity, which is now the delta between those two things, to actually be able to ask and answer questions with some level of accuracy and validity behind it. And so typically, I think we can do that with most health measures. The challenges really come with those new sensor technologies that haven't been field tested. And that's where the understanding of the limitations really has to be front of mind.
Fantastic. Katie, when you were very good to share some examples of things that previously haven't worked terribly well. You talked about the examples where you had this huge sort of outpouring of enthusiasm for using these technologies, and then sort of after you sent them out, sort of quite poor uptake in the absence of training. How do you handle that now? There's a good chunk of information in the playbook around sort of approaching sort of training on technologies. What are some tips and tricks that you guys have found to be useful over time?
Yeah, I think it's making sure that we have the educational and onboarding components tied in. So Ed and I are actually putting together a study right now that is pretty complex. Like it's trying to bring in, like we have participants who are, we're collecting salivary, we're collecting blood in home, we're collecting microbiome, we're connecting a Fitbit, we're doing an Omron blood pressure study or continuous glucose device rather. And so thinking through all of the touch points that are necessary when we're doing this remotely, everything from, I think that the playbook touches on, when do you use visual cues? When do you set up sort of a remote onboarding with a study coordinator who can then walk you through the entire process? When do we need to check back and make sure everything is working? How do we limit? So I think when we originally designed it, everyone was thinking, oh, well, we'll do a 10-day sort of pre-study period where we'll make sure that, they're tracking their diet and they're tracking their fitness and they're connecting all of their devices. And as we looked at the study, we're like, whoa, that's going to be way too long. If you're thinking about things like, I want you to track every time you eat and every diet, having 10 days of that prior to the real 10 days of the study, that's just going to introduce fatigue on that part. So some of this is just looking at it very critically from the very beginning. And then other things are making sure you build in sort of a pilot phase so you can start to gain that information. So some of it we can predict early, like 10 days of diet tracking is a pain in the butt. So you want to make sure you start that as quickly as possible and capture that in the study. Other things are making sure you're testing it out on 50 people before you go out to 300, because there are going to be things that you didn't anticipate going into the study that you'll see a tremendous drop off, or you'll see that it was confusing when I said, link up your, this app or download this other app, and you'll realize that you need somebody to call you and walk you through the process, or you'll need to update your educational materials. So be ready, I think, to go through some IRB amendments with your educational materials and have that built into the study design.
Terrific. Katie, it's a really sort of applied answer. And I really liked how you were talking about sort of, you didn't limit yourself just to sort of training on the technology, but also engaging patients through the whole process of thinking about sort of the optimal design. And I think the sort of extended baseline period example you gave was terrific. Ed, coming back to you, I wonder, you mentioned, and actually Katie, you picked up on it too, you mentioned the importance of your partnership with Care Evolution, and you mentioned the ability of this sort of platform to be able to integrate all of these different data streams to position you guys for analysis. How, as you are increasingly sort of using digital technologies and digital measures in particular in your work, how important is it to sort of forge new partnerships? And sort of what are the nature of those partnerships, and what sort of, how do they participate sort of in the work itself?
Yeah, so I can speak specifically to, how we've come to work with Care Evolution, and I think Katie can chime in just with our stakeholder partners for some of the specific studies and how we engage and interact with them. But with Care Evolution, the partnership has really been built on recognizing that they have their own paradigm in how they've built out My Data Helps that I think aligns well with what we're trying to accomplish. And so, for example, they recognize very early on that they could absolutely, they have extremely talented software developers. And so they could very easily connect with collaborators that for studies A through Z and build out a separate app bespoke for each of those studies. But what they recognize in the power of My Data Helps, what they recognized early was that they can benefit more from identifying those functionalities and that back-end technology that can be consistently used across studies. And so they're very careful in their evaluation of bringing on bells and whistles to the app. And while they may be appropriate for a given study, are they in fact scalable and transferable across a dozen studies or more? And so they talk about, yeah, we may have 50 functions built into My Data Helps, but the 51st function that we add is always going to successively build on the ones prior to that, so that we can always have the ability to leverage them as new opportunities and as new contexts arise. And so that aligns with the Digital Trial Center, in which we're not looking necessarily to really build the center in a study-by-study way. We're really looking to push the field with regards to our vision of how decentralized research can change the way we do clinical trials and research studies. And the My Data Helps platform just fits and suits that perfectly.
Yeah, and I'll just add on to that too. I talked a little bit about scale and accessibility. And so one of the reasons that we partnered, and this is a little bit counterintuitive, we partnered with one technology partner so that we can be more agnostic when it comes to technology and platforms. But Care Evolution, like we could have gotten, some of the same functionality, I think, with Apple, with, Research Kit and with Apple Health Records. Care Evolution allows us to have that functionality for all of our studies that is on iOS, Android, and mobile web. We forge other partnerships with device companies and things like this. We have a partnership with Fitbit. We have a very fruitful collaboration looking at their data sets, but we try and build out all of our studies to be as device agnostic as possible. So if we're looking at sleep, if we're looking at STEP, the way that you get people to engage and remain committed to something, ideally, is using something that they're already using every day and just allowing them to share their data from their device, their platform, their phone of choice. So that's something that we kind of keep in mind as we build out all of these studies.
Fantastic. And one thing I noticed, Katie, I think your remarks during your presentation around how important the language is. I noticed that both of you spoke about partnerships and collaborations. It was never, vendor. And I think that's really important. And as I was listening to you and learning, I thought that was terrific. Sally, you put a great question into the Q&A. If you would like to ask your question, you should be able to unmute yourself at your end and pose it directly to Ed and Katie.
Okay, I think I'm unmuted. Can you hear me?
We've got you.
Yeah.
Great. Hi, Ed and Katie. Good to see you. Thanks
Sally.
for a great presentation. I'm really interested in how we're advancing the calculation of the return on investment and digital tool use. And I'm wondering if you guys are doing any evaluation of the evidence that you're generating and the outcomes that might actually help us have a model for gauging future evaluation and payment for use in public health or even in clinical care, because there just doesn't seem to be a whole lot out there that can guide people on that. Thanks.
Yeah. Hey, Sally, and thank you. I think that's a great question, and it is something that we're exploring. I'll give you an example of something that we're not yet doing, but what we're hoping to do in our pregnancy population study is looking at, collecting blood pressure and activity in home at a continuous level throughout a pregnancy, rather than having somebody come in, and then looking at claims data and looking at costs associated with doing that in the home and deploying those devices out to either a high risk or a general pregnancy population. We've gotten a little bit closer. We're 3 years out of the initial M-STEP study looking at capturing potential AFib by distributing devices out for that. And we're hoping to do a cost analysis of that over time, but we haven't started on any of that work. But I do think that it's definitely on the roadmap for us and of great importance.
Thank you.
Fantastic. Ed, was there anything you wanted to add on that?
Yeah, it's pie in the sky, but I really do think that one day we'll be able to start these presentations with decentralized research has changed the face of healthcare, primarily because we're able to impact this financial model in a meaningful way. But like Katie said, we're setting ourselves up to try and be able to say that through a variety of different avenues.
Fantastic.
Great.
Sally, that was a great question. And I think I just cut you off. I'm really sorry. Go ahead.
No problem. I see it as a real unmet need for all of us who are trying to think about the application of these tools beyond research and really starting to think about ways of being putting a model together that we can start to pressure test as we go along. So thanks again.
Yeah, that'd be great. Thanks, Sally. And if you have any ideas of how we can do that, let us know. Definitely ping us, because that is something that we're looking at.
Katie, you stole those words right out of my mouth. I think that's exactly right. It's exactly where we need to be looking into the future. And so, Sally, it was the perfect question to finish on. With that, just a quick note. I just pasted into the chat. Kostas Makodimitri shot us in the chat a couple of links to standards around the ECG example that we cited in the playbook. So if that's of interest, that's right there for you. And Katie and Ed, before I wrap up and thank you, I want to thank everyone who's on the line today. I appreciate you taking the time out on a big day on the calendar to come and spend an hour with us. Both Katie and Ed, you were kind enough to mention the ongoing work we're doing with the playbook. We've now closed enrollment for the next tour of duty. But I wanted to let folks know that we are going to be sprinting again over the next 6 months to make sure that we work hard to sort of drive adoption and develop the playbook so that it is as impactful as it can be. If that piques your interest and you want to stay up to date and potentially even get involved with some use cases, for example, definitely head on over to playbook.dimesociety.org. Katie and Ed's presentation from today will be posted there a little bit later, along with the rest of the masterclass series. You can also provide real-time feedback. As you use the playbook, we will be taking that into consideration as we continue to forge ahead. And with that, I will stop sharing. Katie and Ed, absolutely tremendous session to end our full Playbook Masterclass series with, and I'm excited for how we might sort of get back to this kind of work in the spring. Thank you everyone for dialing in. We had some really thoughtful questions and appreciate you being on the line with us. So with that, thanks so much everyone. Ping us if you have any questions on the playbook, and otherwise have a tremendous afternoon.
Thank you all.
Thanks everyone, bye-bye.